everyone would like to hear our guest speaker itself. So without further ado, please welcome Dr. Vijaya.
Okay, thank you, Nazim. I think you can see my screen. Can you?
Huh?
Yep.
Yes, yes,
Okay.
you can.
Mungkin ada hack ya.
Okay, so thank you, Nazim, for the introduction, and thank you to the IMU Alumni Association for this invite. It's an absolute privilege to be here. My talk today is actually more or less the same lecture delivered to the ASEAN Federation of Cardiology Congress, which was held earlier this month, looking at our very own dilemma of poorly controlled hypertension in Southeast Asia and how and what we can learn from evidence. And in particular today, what I'll be trying to do is to convince you, ladies and gentlemen, that in order to improve our successes of trying to manage hypertension and its control in our society, in our population, we need to get it right from the start. Half the battle is won when we do the right thing from the very beginning. So these are my disclosures. I don't have any conflict of interest today. There's no financial remuneration is involved today. So hypertension is highly prevalent in Southeast Asia, as you can see from this heat map. And this is a study was published in Lancet in September, a couple of months ago. And hypertension is also the #1 risk factor for mortality. And it's a big problem in East and Southeast Asia, in our parts of the world. Hypertension is also more dangerous for Asians because for every millimeter rise of systolic blood pressure above normal, more Asians than Caucasians will have coronary heart disease, and even more Asians than Caucasians will have strokes. And not only mortality, but it leads to a great amount of disability. This is the percentage of disability adjusted life years, the number of life years a person lives disabled. As you can see, high blood pressure is the leading cause of disability, presumably sequelae of strokes and heart failures. So despite hypertension being highly prevalent in Southeast Asia, and it's more dangerous for people who are living in this region, its control is still very poor in our parts of the world. And it's also highly variable from nation to nation in Southeast Asia, with countries like Brunei and Singapore being more urban population and higher GDP, having a control rates that's equal or better than some of the higher income Western nations. But rest of the Southeast Asian nations have control rates less than 50% of those who are treated. That's including our beloved Malaysia. And in this graph, you can see, this is a graph looking at proportion of patients who are diagnosed with hypertension. That's the blue chart. Treated for hypertension, that's the green bar. And the red bar is the control. And in Southeast Asia, we have one of the worst controls in the world. We are only slightly better than some parts of sub-Saharan Africa. And uncontrolled hypertension is bad because in the large enhanced survey, we found that those who have hypertension and not treated, and those who have hypertension treated, but the BP is not controlled, are equally at increased risk for cardiovascular events compared to those who are treated and controlled. So if you're going to treat someone for hypertension, get it under control. So why are we struggling to control blood pressure? The 2018 European document for hypertension have put it quite succinctly that among the reasons for poorly controlled hypertension are as following. #1, poor adherence to treatment, that's patients. #2, complexity of current treatment strategies, which I'll be demonstrating later, treatment inertia, and insufficient use of combination treatment, which means combining two different antihypertensives from the very beginning of someone's hypertension timeline. And in Southeast Asia, we have our own unique local and regional challenges. So first we'll look at the poor adherence to treatment. So in order to beat poor adherence, so some of the factors that leads to poor adherence of treatment that's well recognized in the literature as following: pill burden, too many pills, financial costs, expenses, side effects of medications, and lack of efficacy of antihypertensive medications, and also the strategy, for example, insufficient use of combination treatment. So in response, the 2017 American Hypertension Guidelines, the 2018 European Hypertension Guidelines, the 2020 International Society of Hypertension Guidelines, and the 2020 Canadian Hypertension Guidelines, as well as some more local guidelines like the Malaysian Hypertension Guidelines and the Indonesian Hypertension Consensus, have all come up in unison and recommended the use of single pill combination as the first line treatment for all grades of hypertension, including grade 1 hypertension, with very little or few exceptions. Now, using combination medication, the recommendation is try to use single pill combination as much as possible compared to free combinations, because there'll be increased chance of blood pressure control over 1 year. And there's also quicker time attained to control blood pressure by using single pill combinations compared to free combinations of the same medications. And we know when we have to strive to reduce the number of dosing and the number of pills per day, because merely increasing dosing by 1 to twice a day have been shown in hypertension studies to reduce the compliance of our patients or adherence of our patients to medications by a whopping 10%. And hypertension studies have also shown us that among patients with high adherence to treatment, there's up to double-figure relative risk reductions in heart failures, coronary artery disease, and strokes. So this calls for the first pillar of blood pressure control, which is the use of single pill combination whenever or wherever possible. Second factor, complexity of current treatment strategies. Now, we live in a region where we share very similar geography, very similar weather, very similar food, and our population have almost very similar genetic pool. And despite that, you can see from nation to nation, there's such a huge variation when it comes to treatment thresholds in elderly patients, high-risk patients, and also the target blood pressure involving general population, elderly, or high-risk populations. Now, this leads to complex treatment thresholds and blood pressure targets, which can be hugely misleading, creates a lot of confusion, and the end result is the prescribers of hypertension medications, i.e. the doctors in this region, will be, that leads to lack of confidence to them, because there's such a huge variation in blood pressure, treatment thresholds, and targets. So what we should do is to adopt a single guideline or single document, a single guideline that will make things easier to follow, simpler to follow, and should be evidence-based. And one such guidelines that I will urge you to follow, because we don't have a Southeast Asian guidelines, is to look at the International Society of Hypertension Guidelines, which has made it very simple. Anyone above blood pressure above 140/90 should be treated, and the target should be less than 130/80, except if you're elderly, then the target could be a bit more relaxed at less than 140/90. Now, this in hindsight is spot on, because the latest STEP study, which was published only this year, have shown us that among elderly Asian patients, we can actually target blood pressure to much lower levels than what's been advocated by the Malaysian and Singapore guidelines at the moment, which is less than 150/90. So in hindsight, the ISH guidelines has got it spot on. And to be honest, Indonesia has already been doing what the ISH guidelines recommends as far back as in 2019. So there are some good things that we can try to follow one another in this region. So this calls for the second pillar for blood pressure control, which is simplicity of guidelines. The complexity of treatment strategies also extends to the use of combination treatment and to the choice of combination treatment. For example, in Brunei, combination treatment is recommended for grade 2, in Singapore, grade 3, and in other Southeast Asian nations, an arbitrary number of systolic BP of 150 and above, and in Malaysia, everyone except for low-risk grade 1 hypertensive patients. Again, this leads to and comes to the choice of combination treatment. Some nations recommend an A and a C, that means your ACE inhibitor or ARB with calcium channel blocker. some countries A and a C or a D, which is D is diuretic, and other nations we can even use a calcium channel blocker and a diuretic. And this again leads to complexities in the choice of initial treatment, giving rise to very misleading information, creates a lot of confusion and also lack of confidence to the prescribers. So once again, I think the ISH guidelines have got it correctly. They have recommended that all patients should go on combination medications, ideally a single pill combination medication. And this has already been done in Malaysia a year before the ISH guidelines came out. So what it shows is that we should sit down and come up with a consensus, because some of the good things that being advocated around the world has already been done locally. So this calls for both simplicity in guidelines and the use of single pill combination wherever or whenever possible. The next two factors, treatment inertia and insufficient use of combination treatment, are highly interrelated. So in order to beat treatment inertia, both the European guidelines and the 2020 International Society of Hypertension guidelines have recommended as a first-line treatment that you should be ideally using combination medication and ideally a single pill combination treatment. But what happens in our region is that most patients will start with one drug, then they'll come back for an appointment in a couple of months. We find their BP is not controlled, so we increase the dose of first drug. Then we find they have side effects, or BP is still not controlled. So a couple of months down the line, we'll add a second drug. We find the BP is not controlled. Then we'll change the second drug or add a third drug. You see, this process is incredibly elaborate and time-consuming, and may miss an important target of trying to get blood pressure control within 3 months, which is both the European guidelines recommendation and the recommendation by the International Society of Hypertension guidelines. Now, why do guidelines recommend quick blood pressure control? That's because a lot of hypertension studies have shown us that the quicker we get our patients' blood pressure under control, the lesser cardiovascular events they'll be exposed to. For example, in the famous VALUE study, patients with hypertension were randomized to either valsartan or amlodipine, and it didn't matter which blood pressure arm they belonged to. Those who had blood pressure control within a month had subsequently lower cardiovascular events by 12% during the follow-up period. So this calls for the pillars of single pill combination and speedy blood pressure control within 3 months. So just to give you a snapshot of treatment inertia in Southeast Asia, we'll look at a study from Thailand published earlier this year. So they looked at whether dose adjustments were performed when they were required, and up to 28% of patients, that's more than a quarter of patients, did not get dose adjustments during their follow-up when they should have got, when they should have received a dose adjustment. So this is typical of treatment inertia, and this continuous same syndrome also happens in Malaysia. And they also looked at whether they got the right choice of medication, i.e. monotherapy or combination therapy, and up to 55% of patients did not get combination therapy that they deserve to. So this, of course, is the insufficient use of combination treatment. So despite the recommendations to use combination treatment, we still don't practice that enough. And why do guidelines recommend the use of combination treatment? That's because a lot of hypertension studies or the large hypertension trials in the last few decades have shown us that the average number of antihypertensive medications that we require to control our population's blood pressure is between 2 and 3 medications in the trial. Wald and colleagues from Toronto and Canada have also shown us in their meta-analysis that the extra blood pressure reduction from combining 2 different drugs is 5 times greater than doubling the dose of an existing drug. So you can see in this meta-analysis of 11,000 patients from 42 different trials, the extra blood pressure reduction as depicted by the yellow bar chart is much more prominent when another drug was added from a different class compared to doubling the dose of same drug, which is depicted by the orange bar charts. So in the UK, there was a matched cohort study by Karin Marinia's group, which showed that among patients with grade 2 and 3 hypertension, those who started with a 2-drug strategy, i.e. combination strategy, had up to 38% better chance of blood pressure control in 1 year compared to monotherapy. Now, this is not surprising because these patients had a high baseline blood pressure above 160. But what about grade 1 hypertensive patients whose systolic BP is between 140 to 159? Even in this group of patients, studying them on 2-drug strategy conferred them 15% better chance of blood pressure control in 1 year. And studies like this have given us a great confidence that we should be using combination treatment even for grade 1 hypertensive patients. So gone were the days where we start monotherapy and then escalate. The famous Giuseppe Mancia's group from Monza in Italy have also shown us that in addition to better blood pressure control, using combination treatment will also lead to reduction in cardiovascular events driven down by coronary and cerebrovascular endpoints. And what's even more interesting is that they showed that those who started with the one drug and then went into combination treatment had an odds ratio of 1, which means not much effects on the cardiovascular outcomes compared to those who started with the combination treatment and maintained on a combination treatment. Their odds ratio was 0.74, meaning to say there was up to 26% cardiovascular risk reductions in patients who started with the combi and maintained on a combi compared to starting on a monotherapy and then only escalating to combination treatment. So this calls for the pillars of single pill combination and speedy blood pressure control. So ladies and gentlemen, therefore, the 3 pillars to improve blood pressure control in our population will be the 3 S's: the simplicity in guidelines, the single pill combination, and the speedy blood pressure control, aiming to control blood pressure within 3 months. But we also have our local and regional challenges in Southeast Asia, and these are among the challenges that we are facing. And some of these challenges are beyond the remit of today's talk, because we will need governmental and legislative changes. For example, what's being done in Thailand. Thailand have introduced salt tax in order to reduce salt consumption in the population, and Malaysia have got their own salt reduction strategy. And all these have already starting to bear fruits. We can see Malaysia is depicted by the blue coloration, which you can see there's already been some reduction in salt levels of food. And Thailand, which has just started, we haven't seen improvements yet, but a strategy is there. We also need help from non-governmental organizations, advocacy organizations, and also our industrial partners, industry, to come and help us with some of the local and regional challenges. And we also desperately need a regional approach or a consensus, because we seem to have a great variation in what we do from nation to nation within Southeast Asia. So as I said, some of these things are beyond the remit of today's talk, but 2 factors that we clinicians in this region should recognize is that we have higher salt-sensitive hypertension and higher cardiovascular risk burden in this region. So first, the higher salt-sensitive hypertension is mainly due to genetic predisposition. We Asians have carry a lot more genes that makes us very sensitive to salt. Consuming a bit more salt in our population will lead a higher or greater blood pressure rise compared to the same Caucasian populations. And we also have one of the highest consumers of salt in the world. We also have a high cardiovascular risk burden in this region. As you can see in this heat map, we have one of the highest mortality from ischemic heart disease and also strokes in Southeast Asia. So really, the 3 pillars of blood pressure control in the context of Southeast Asia, the single pill combination, simplicity in guidelines, and speedy blood pressure control, has to be married with the 2 local factors, the higher salt-sensitive hypertension, higher cardiovascular risk, in order to give rise or give birth to the 6 commandments for managing hypertension in Southeast Asia. Commandment number 1, we have to make treatment threshold simple and treat everyone above a blood pressure of 140/90. Of course, this is just a guidance. Treatment of hypertension should be always individualized, but this is a general advice. And they should be targeted to less than 130/80. Unless you're elderly, then you can be a bit more relaxed. Then you should ideally use a single pill combination. And if you can't, at least use a dual combination as initial treatment for most of our hypertension patients, and try to get a speedy blood pressure control within 3 months. And Our first line combination should always be a A and a C or a D. This is where we digress from the ISH guidelines because we have more salt sensitivity here. So we should consider also a D instead of a C in some of our patients. As long as that A is an ACE inhibitor, especially in those with higher cardiovascular risk. So we have been taught in probably medical school and throughout our training that ACE inhibitors and ARVs are really the same thing and they can be used interchangeably. But really, that's not true. ACE inhibitor should be considered as a first-line drug, and ARB should be considered only in patients who are intolerant to ACE inhibitors. Am I being controversial? No, because that's what evidence tells us. See, in 2006, in one of the largest meta-analysis of hypertension involving more than 200,000 patients, they looked at ACE inhibitors versus comparators and also ARBs versus comparators. In ACE inhibitors versus comparators, there was a reduction in all-cause mortality, cardiovascular mortality, trended towards lesser strokes and reductions in myocardial infarctions, whereas there was a trend towards higher all-cause and cardiovascular mortality in ARBs versus comparators, granted less strokes, but a statistically significantly higher myocardial infarctions in the ARB group. And this is in keeping with the prevailing theory in the literature that could be an ARB-MI paradoxical relationship, a relationship which means higher myocardial infarctions or heart attacks with ARBs. And this is not new. As far back as in 2003, in the famous VALUE trial, where patients with high cardiovascular risk and hypertension were randomized to either valsartan and amlodipine, it was published in a very reputable journal, The Lancet. And this study was funded by Novartis, the makers of valsartan. So not only Novartis, but the rest of the world thought valsartan here will be home and dry because it was competing against amlodipine and not necessarily a drug that's been associated with the reductions cardiovascular events apart from what its blood pressure reductions would do. And what they found, and the world was in shock, when there was a 19% increase with statistical significance in myocardial infarctions in the valsartan group. And for the first time, there was a huge hue and cry and debates in the literature that could be a ARB-MI paradoxical relationship. And that relationship was further strengthened the same year when the CHARM alternative trial was published. And in this trial, patients with heart failure were randomized to either candesartan or placebo. And surely candesartan cannot have higher MIs than placebo, but that's what it happened. There was a 52% increase in myocardial infarctions with statistical significance in the candesartan arm. But this was no longer surprising because 9 out of the subsequent 11 key trials have shown us that ARBs have excess MI. So if you look at this forest plot chart, the graph is skewed towards the right in favor of control, moving away from ARB with the 8% rise of myocardial infarctions in the ARB group. I think the most important takeaway, though, from this forest plot chart is the I-squared test of 14.6%. For those of you not very familiar with statistics, an I-squared test is a test of homogeneity, and anything less than 30% means the studies are highly homogeneous to one another, meaning to say this seems to be an ARB class effect. And in 2012, this time looking at the meta-analysis of all-cause mortality, once again, ACE inhibitors save lives, ARBs didn't. What's most interesting, though, is the 3 ACE inhibitors trials that produce the most reductions in all-cause mortality are trials using perindopril. Now, I don't have the luxury of time to go through these in detail, but perindopril produces one of the greatest benefits because it has a long duration of action due to its high trough to peak ratio. It's also converted to an active metabolite in our body called perindoprilat, which is highly lipophilic, meaning to say it can penetrate the tissues better and bind to angiotensin converting enzymes better, leading to a greater stimulation of nitric oxide, substance P, bradykinin, etc., which has a plethora of cardiovascular benefits. Perindopril have been shown time and time again in the early 21st century that they are versatile drug. They can reduce cardiovascular events and MIs in various populations. For example, in stroke populations, in high-risk cardiovascular populations, in hypertension populations, diabetic populations, and also elderly populations above the age of 80. So now looking at a meta-analysis on a different population, this was not a general population, but a population of patients with chronic kidney disease. a group of patients, my nephrology colleagues sometimes tend to favor ARBs because ARBs had dedicated renal outcome trials, whereas ACE inhibitors didn't bother to do dedicated renal outcome trials because they were very well established by then. But over the years, we have mountains of evidence now looking at secondary analysis and post-hoc analysis to do network meta-analysis to compare, to make meaningful comparison between ACE inhibitors and ARBs. And this is where we can see that, yes, both ACE inhibitors and ARBs reduces kidney failure, but ACE inhibitors does better than ARBs. But once again, when it comes to cardiovascular death, ACE inhibitors save lives, ARBs doesn't. And when you compare ACE inhibitors versus ARBs, ACE inhibitors obviously does so much better. In 2017, there was another systemic review, but this time a systemic review of other meta-analysis. And one of the meta-analysis was, of course, from Sripal Bangalore's group. Sripal Bangalore from America is one of the forefront advocates of ARBs. And even when we included his meta-analysis in the systemic review, there was reductions of cardiovascular death in the ACE inhibitor group versus placebo, whereas there was an increase in cardiovascular death in ARBs versus placebo. And the reductions in mortality that was seen with ACE inhibitors extends across various populations, in hypertensive patients, in diabetic patients, in patients with coronary artery disease, and high-risk patients, whereas ARBs doesn't. So this has led to finally a recognition that ACE inhibitors and ARBs are not interchangeable. And in 2019, the European guidelines for diabetes have suggested that use ACE inhibitors as first line because of the strong evidence from systemic reviews of randomized controlled trials, and ARBs should only be administered in patients who are intolerant of ACE inhibitors. A year later, in the 2020 European guidelines for acute coronary syndrome, once again, ACE inhibitors should be used as first line, ARBs only if you're intolerant to ACE inhibitors. And a year later, across the English Channel in the UK, for acute coronary syndrome, the NICE guidelines have come out and recommended the use of ACE inhibitors as first line and indefinitely, and only use ARBs if you're intolerant to ACE inhibitors. The momentum against ARBs continues in 2021, when the latest guidelines for treatment of acute and chronic heart failure came out and recommended that ARBs are only recommended if you're unable to tolerate either an ACE inhibitor or ARNIs, which are the latest class of medications for heart failure. So I think the evidence is beyond reasonable doubt that we should be using an ACE inhibitor, especially in those with high cardiovascular risk. So, ladies and gentlemen, in summary, we should treat blood pressure above 140/90, target blood pressure less than 130/80 unless you're elderly, use combination medication as much as possible, ideally a single combination, aim for blood pressure control within 3 months. First line combination should be A and a C or a D, as long as that A is an ACE inhibitor, especially in those with higher cardiovascular risk. So that, I'd like to thank you for listening. And I'm going to quote my former boss in England, Sir Liam Donaldson, who once said, if you always do what you always did, you always get what you always got. So if we're going to continue using monotherapy as we always have done, and using treatments that is not very evidence-based, then we're going to continue to have one of the highest mortality rates from ischemic heart disease, one of the highest mortality rates from strokes, and one of the highest renal failure rates in the world in Southeast Asia. So if we want to change that, we have to change what we do from the very start. Thank you.
All right, thank you, Dr. Vijaya, for the very fruitful and interesting talk. Would like to ask the participants of the floor, do you guys have any questions to raise up to Dr. Vijaya? Because right now we can have a short Q&A session. If you guys want, you can unmute your mics or you can leave your question in the chat box. Okay, so we have a question from a participant. You may unmute your mic or you may choose to put your question in the chat box.
Hi there, Dr. Vijaya, can you hear me?
Yeah, I can.
Yeah, I'm Dr. Kasim Suk from Thailand. I'm an emergency physician working in the emergency department. So we see a lot of hypertension cases coming with blood pressure 180 something in the emergency department. So for us as an emergency medicine specialist, do we start the medication straight away, like calcium channel blocker and ACE inhibitor straight away, or you recommend we initially start for 1 week, something like a CCB, and then we let the specialist continue with the medication? Thank you.
I think the answer, that's a very good question. So the way we manage hypertension also differs if they come to emergency department with hypertension emergency or hypertension urgency. For example, if you have a systolic blood pressure of 180 and you have headache or you have left ventricular hypertrophy, you have renal failure, this means you have end organ damage. And these patients need urgent treatment. They should be admitted. They should be given IV labetalol or IV GTN to bring down the blood pressure to a more safer level, because these patients, by definition, have hypertension emergency or hypertension urgency. On the other hand, if you have a patient with a chronic high blood pressure over time, and these patients are very well with no end organ damage signs, then I think you can refer them to the specialist. If you don't have access to specialists on the same day, you may start them on combination medications. Now, the guidelines have suggested if you have grade 1 hypertension with no target organ damage, you can wait 3 to 6 months before you put them on medications, as long as they have low risk for cardiovascular events. But if you have grade 2 and 3 hypertension, which means a systolic BP above 160 and above, then you don't have the luxury of time to wait. Then I think if they don't have hypertension emergency or hypertension urgency, and they don't have the access to the specialist on the same day, doctor in Thailand, in emergency department, then I suggest you start them on a combination treatment. Now, they might not afford single pill combinations. You may, I mean, in that sense, you can use, separate pills, like you said, a calcium channel blocker and an ACE inhibitor. Of course, you need to check the renal function, making sure they don't have end-stage renal disease before you put them on ACE inhibitor, etc. But otherwise, if they are fit and healthy and there's no contraindication, they should go on an ACE inhibitor, especially if they have high cardiovascular risk, and a calcium channel blocker. Putting them on a monotherapy alone is going to be insufficient. Studies have shown yet time and time again, these patients will succumb to a poorly controlled hypertension and also to cardiovascular events if you put them on monotherapy. I hope I answered your question. I'm happy to have a follow-up question from you if there's any.
Okay, thank you very much. I think you answered the question quite well, doctor. Just that we don't have the luxury of the combination pill, so we just have to order the 2 types of pills.
I agree. I mean, even in the UK, we didn't have single pill combinations in the National Health Service. So we use separate pills. Here, I work in a private healthcare, so I have access to single pill. Now, the advantages of single pill is basically compliance, because less number of pills, so compliance is better. But if you don't have them, that's okay, because even the UK doesn't have them. So they use separate pills, but 2 different pills.
Thank you.
Okay, do we have other questions from the participants? We will give approximately a minute or 2. If you have your question, please type down in the chat box, or you can unmute your mic. Okay, I think that's it. I don't think there's any more further questions from the participants. Okay, once again, the Alumni Office and the IMU Alumni Association would like to thank Dr. Vijaya for accepting our invitation for this talk. It was truly fruitful, and we hope that all the participants have learned many things, especially regarding the topic of hypertension.
You're welcome, Angela.
Yep.
Thank you. Yeah.
Okay. Oh, okay. Yeah. Thank you. There's a comment thanking Dr. Vijaya.
You're most welcome, everybody. Yep.
All right. Thank you, everyone. I'll be ending the meeting soon. Okay, if you have any last questions, you can still type in the chat box if any. But I think that's all. Okay, thank you so much, Dr. Vijaya.
Thank you and
All
bye-bye.
right, thank you for everyone's time.